Asthma is a chronic inflammatory condition. Asthma is a chronic inflammatory condition of respiratory tract characterized by an increased responsiveness of the trachea and bronchi to various stimuli and presenting of reversible airflow limitation. Asthma is a chronic inflammatory condition of the respiratory tract characterized by an increased responsiveness of the trachea and bronchi to various stimuli and presenting of the reversible airflow limitation. Clinical features of acute severe asthma or status asthmaticus. Clinical features. Symptoms. General examination and examination of the chest. Symptoms, general examination and examination of the chest. Symptoms includes recurrent cough, nocturnal episodic cough, then breathlessness or shortness of breath, chest tightness and wheeze. General examination, dyspneic, flare of the ala of the nose, prominent accessory muscle, ear hunger, cyanosis, altered sensorium. Examination of the chest. Inspection shows tachypnea, hyperinflated chest, presence of suprasternal, subcostal and intercostal recession. Suprasternal, subcostal and intercostal recession. Tachypnea, hyperinflated chest, presence of suprasternal, subcostal and intercostal recession. Palpation, reduced chest expansibility, central trachea, reduced chest expansibility, central trachea. Percussion, hyper resonant, auscultation, vesicular breath sound with prolonged expiration and shows rhonchi. Very, very important, rhonchi. Vesicular breath sound with prolonged expiration and rhonchi. Investigations. Number 1, chest X-ray, blood, Number 3, sputum examination. Number 4, peak expiratory flow rate. Number 5, others. Chest X-ray shows hypertranslucent and hyperinflated lung, low diaphragm and horizontal ribs. Blood shows eosinophilia, high immunoglobulin E level. Sputum examination shows eosinophilia, eosinophilia, peak expiratory flow rate shows diurnal variability more than 20%. Diurnal variability more than 20%. Others shows spirometry, bronchial reversibility test. Spirometry and bronchial reversibility test. Now management of acute asthma. Management: salbutamol number 1, salbutamol nebulization. Number 2, propped up position. Number 3, oxygen inhalation. Number 3, oxygen inhalation. Number 4, injection hydrocortisone. Then ipratropium bromide, injection adrenaline, Maxalf. In refractory cases, ICU support. Salbutamol nebulization. 0.15 to 0.3 milligram per kg per dose. Every 20 minutes for 3 times or continuously. If nebulization is not available, then continuous inhalation of salbutamol by inhaler. If nebulization is not available, then inhalation of salbutamol by inhaler with spacer may be tried at home and on the way to hospital. Then position: propped up position. Oxygen inhalation 4 to 6 liter per minute. Injection hydrocortisone 3 to 4 milligram per kg. 4 to 6 hourly. Or prednisolone, hydrocortisone and prednisolone 2 milligram per kg per day for 3 to 5 days. Or as necessary. If condition does not improve, nebulized ipratropium bromide may be added. If condition is still shows no improvement, then injection adrenaline may be tried. If still no improvement, magnesium sulfate IV. In refractory cases, ICU or ventilator support. Review. Asthma is a chronic inflammatory condition of the respiratory tract. Chronic inflammatory conditions of the respiratory tract characterized by an increased responsiveness of the trachea. And bronchi to various stimulants presenting of reverse airflow limitation. Clinical features: symptoms, general examination and physical examination. Symptoms: general examination and chest examination. Symptoms: recurrent cough, nocturnal episodic cough, breathlessness or shortness of breath, chest tightness and wheeze. General examination: dyspneic, flare of the allowed nose, nasal prominent accessory muscle, air hunger, cyanosis, altered sensorium. Examination of the chest on inspection: tachycardia, hyperinflated chest, presence of suprasternal, subcostal and intercostal recession, palpation shows reduced chest expansibility, central trachea. Percussion: hyper-resonant. Auscultation: vesicular breath sound with prolonged expiration. Okay. Investigations: chest X-ray, hypertranslucent and hyperinflated lung, low diaphragm and horizontal ribs. blood, eosinophilia, immunoglobulin E. Eosinophilia and immunoglobulin E. Sputum examination, eosinophilia. Peak expiratory flow rate, diurnal variability more than 20%. Diurnal variability more than 20%. Others, spirometry, bronchial reversibility, spirometry and bronchial reversibility test. Management of severe acute malnutrition. Salbutamol nebulization, 0.15 to 0.3 milligram per kg per dose for 20 minutes for 3 times or continuously. If nebulization is not available, then continuous inhalation of salbutamol by inhaler, then by inhaler with spacer may be tried at home and on the way to hospital. Then propped up position, oxygen inhalation 4 to 6 liter per minute, injection hydrocortisone 3 to 4 milligram per kg 4 to 6 hourly or prednisolone 2 milligram per kg per day for 3 to 5 days or as necessary. If condition still shows no improvement, injection adrenaline may be tried. Injection adrenaline. If condition does not improve, nebulized ipratropium bromide may be added. If still shows no improvement, injection adrenaline may be tried. If still no improvement, magnesium sulfate IV. Magnesium sulfate IV. In refractory cases, ICU or ventilatory support. In refractory cases, ICU or ventilatory support. A 5-year-old boy was brought to the scenario. 5-year-old boy was brought to the emergency department with cough, wheeze, and severe respiratory distress. He has a history of atopy since early infancy. What is the most likely diagnosis? Acute severe asthma. Outline the treatment plan for this baby. Treatment plan and immediate management, long-term treatment. What clinical parameters will you look monitoring during his hospital history? Now treatment plan, immediate management, salbutamol nebulization 0.15 to 0.3 milligram per kg per dose every 20 minutes for 3 times or cautiously. If nebulization is not available, then continuous inhalation of salbutamol by inhaler with spacer may be tried at home and on the way to hospital. Immediate management also includes propped up position, oxygen inhalation 4 to 6 liter per minute, and injection hydrocortisone 3 to 4 milligram 4 to 6 hourly, prednisolone 2 milligram per kg per day 3 to 5 days or as necessary. Long-term treatment shows asthma education, regular use of preventive drugs, inhaled corticosteroid, chromins, and leukotriene antagonist. Regular use of preventive drugs. Preventive drugs includes inhaled corticosteroid, then chromins, and leukotriene antagonist. Regular monitoring of lung function by peak flow meter. Maintain asthma diary. Avoid triggering factors as far as possible. Avoid triggering factors as far as